Very good morning, everyone. I think looking forward to a highly interactive session on Cataract Panorama. Basically, what we are going to be covering in this session is simple day-to-day situations that we face in cataract surgery. And I have a very eminent panel. Some of them are still likely to join. I hope we'll have a better audience soon. And where I'm going to be presenting short snippets of how I do certain cases and elicit from this eminent panel as to other ways in which they would handle this particular case. So this is something we have been doing on a regular basis in various fora, and it's a highly interactive session, and being a limited crowd, I think the audience are also invited to participate. Let me just first start off with a small pupil IFIS case. I think many of you would consider this 4 millimeter pupil is a 8-year-old gentleman with history of prior Tamisulos in use, and I often make a difference between small pupil and small rhexis phacoemulsification, and I always stain the capsule, and as you can see I am running the rhexis just under the pupillary margin, so it gives me about a 4.5 millimeter rhexis, and it's a direct chop that I am doing, creating a small trench which gives me access to the meat of the nucleus. Then subsequently it's a grade 2 grade 3 cataract, so very choppable cataract. As you can see, I keep the intraocular pressure as 30, but the vacuum is at 550 or 600, where I am and as and when occlusion occurs, it tends to rise up. Active sentry is also there, and all the phacoemulsification, all the maneuvers you might have noticed happens right in the area where visibility is good, and I keep the intraocular pressure low, and I'm literally wait for the nucleus fragments to flow into the phaco tip, and it's held in a oblique manner. And I always favor a irrigation bimanual irrigation aspiration, and then subsequently the ASM in case we need to discuss about it. That's how it was. Comments, Dr. Tityal? Anything else? Any other way you would have handled this?
That, I think you've done a great job for this particular case. I think, as I know, surgeon, we need to assess the patient very carefully. What Dr. Ramamurthy was talking about. There's a history of patient which is Tamsulan in use. We all know that patient may have a floppy iris syndrome. Other eye examination is very critical. If you see other eye already pseudophakic, you telltale signs of a difficult surgery, you can understand this patient might give a little challenge, and that's also a very important point. People talk about giving atropine pre-operatively, which I don't practice as such because it's not required. We can manage these patients very effectively. I have only 2-3 points here to identify which type of pupil we are dealing with. Sometimes there is a floppiness you can appreciate right from the beginning, the flutter. When you doing the incision, when injecting something, that pupil might constrict. Like this was a rigid pupil, like it remains static throughout the surgery. One is pupil as such, other is the parameter you are nicely set up. Low parameters, low IOP, fluidics are very nicely managed, and that is very important for these type of cases. Not only for small pupil, for other difficult cases also, like polar cataract, subluxated, this type of procedure has to be done. The only challenge we face sometimes in a toric IOLs or a multifocal toric IOL, whether your toric lens has to be fixed in a particular axis, you can't see those marks with a slightly smaller pupil. There you have a little challenge. And for people, you find any difficulty, you can use iris expander devices, the hooks, anytime, whenever you feel like, and complete your surgery in an effective manner. So that's only teaching, and you did a wonderful job here.
Partha, you would have, considering the history and a medium pupil, would you advocate that you straight away put in iris hooks or say a VX ring or something like that, or would you do what I did?
So, a very nice case and a very good case for discussion. I will not repeat Professor Tityal's points, but one thing that is very important is this was a grade 2, grade 3 cataract, which was amenable to a direct chop. So, in such cases, and with the pupil coming down, it is quite amenable even if it's a 4.5 millimeter axis. However, had this been one with a soft cataract, there which is not always choppable, and a direct chop is not always possible. So there, the possibility of hooks and devices are more important at any point of time. The other thing that you did absolutely well, sir, I think, and that is you did, the nucleus was taken out, and over the iris you emulsified. Now, in such cases, if you emulsify under the iris or at the iris plane, immediately the gush of fluid pushes up, and if it's a tamsulosin eye, then everything comes out from the ports and becomes messy and more difficult. So,
Any comments, Chitra?
Surgery was wonderfully done, but I would prefer to use hooks so that my rhexis becomes larger. You can still retract the iris and continue to make it a little larger rhexis, but the visibility is there, and it makes the case so much more straightforward. And senile myotic pupil, normally the pupil size could remain the same, but it could come down too. So I wouldn't take a chance, but yes, that's another wonderful way of doing the surgery.
Dr.
Anurag, you
Chitra,
are a great advocate of low
can I
IOP.
put a question to her.
frequency.
Would you like to use an intracameral Jalocaine or something which can maintain the pupillary dilatation and make the patient comfortable also?
Yeah, but in a senile myotic pupil like this, it doesn't help. You could do it as a preliminary step, and just even if you get a ½ millimeter more, you can judge. This kind of density of the cataract allowed him in a softer cataract or a harder cataract. It's an unnecessary risk to take. So 90% of situations I would use iris hooks only.
You are a great advocate of low IOP frequency. Pertinent to this situation, could you just comment on that? I think most of the other points have been covered by the
Absolutely, sir. I think when we saw the case summary, which you showed at the end, we saw that 96 milliliters of fluid were consumed, and the case took 11 minutes, which of course sends a very strong message that in these situations you should go slow, even it takes a wee bit of more time. But what it also means is 96 milliliters of fluid consumed will also mean that we are creating more fluid turbulence, which also is likely to cause that minor fluctuations in the AC, which also brings down the pupil. So in this particular case, the only thing I would have done differently is I would have kept the IOP at 30 or maybe even lower, but the aspiration flow rate would be in the range of 23 to 25 with me, because that's what actually creates those minor, we can still see that. So it's just a wee bit of fluctuation that could just bring down the pupil a little more. The other thing I would have done little differently in here is to divide the heminucleus into 3 pieces instead of 2, so that when you are dislodging them from the bag, there's no manual touch to the pupillary margin. So that
Actually, I chopped it into 4 pieces. I did a first initial chop
I
and
saw
then
that, yes.
each chop.
You've done it
was-
very well, sir.
Yeah.
You've done it very well. So I'm just saying that what I would have done is probably divide into 6, 3 pieces each, so that the pieces are even smaller. So when they're dislodging from the bag, there's no manual touch with the pupillary margin. That's the only other thing. But otherwise, the pupil has stayed very well, all thanks to the patients that you've exhibited.
Great. Let's pass on to another situation, hard brown nuclear cataract, and this is good dilatation. One of the most important things in these cataracts is to get an adequate rhexis, and I think 5.5 millimeter rhexis size is what I aim at, running almost at the right at the periphery of the lens, and getting a good excessive hydrodissection should not be done. Just enough fluid, because often it's associated with the zonular weakness, and you don't want any compromise on that. And this is running at double the speed. In these cases, and in most cases, I always create a mini trench up to the center of the pupil, and then that gives me excellent access to the meat of the nucleus. And burying my phaco tip into the meat of the nucleus, I do this direct chop. And essentially, it's important that the lateral separation is also not excessive, because that itself might cause quite a bit of stress on the zonules. And it's also important that the number of segments, as Anurag mentioned, I make is directly proportional to the hardness of the nucleus. In this case, I'm making it into 6 segments, 2 heminucleus being chopped into 3 bits each. And each time, I just make sure that these nucleus segments are completely separated. If they are connected by interdigitating fibers, then the rest of the procedure. This is an important step I would like you to see, where I'm injecting viscoat. This is the only step I use dispersive viscoelastic to coat the endonucleus to endothelium, and subsequently having a well of HPMC. so there's no thermogenic damage, and then subsequently going ahead with the rest of the surgery. And I am repeating the same maneuver after one heminucleus is removed, because protecting the endothelium with these hard nucleus is quite important. And as you can see, the CDE is reasonably high, though for this kind of a cataract I think this is reasonably acceptable. And I use only longitudinal phaco when it comes to chopping, and use only torsional phaco during the quadrant removal, and that's just a little bit of hydro polishing, that's hydro implantation of the intraocular lens. We'll see a slightly more detailed video of that. Comments, let's go the reverse way from you, Anurag.
Yeah, I've watched you during live surgery, sir, and I love the idea of using only longitudinal for chopping, which actually gives the needle an advancing movement instead of the sideway sculpts. Everything else is absolutely superb. As I've maintained before, for no grades of cataract, I changed my fluidic, so I would have still stayed with an IOP of 20. I always believe that that's more soft on the endothelium. Even after coating the endothelium, it's just something that ensures that the endothelium does not get any fluid surprise or any fluidic bang on it. So the IOP would have stayed at 20 and the flow rate would have stayed at 23. But I would have kept the IP switched on instead of using longitudinal for chopping. I'd use torsional, but use the IP in its maximum setting, so that the moment it achieves 90% of vacuum, the longitudinal phaco starts operating. So that will be deep inside the nuclear substance when the longitudinal starts operating, and gives me that depth wherein I can hold it and chop it. That's the only thing I'd have done different. But CD count is superb, sir. I think you need a clap for that. For 22 odd for this sort of a case, it's absolutely brilliant.
Actually, just to clarify, very pertinent point. This is a slightly older video. Nowadays, I stick to not to your level of 20, but I stick to a IOP of 30 almost in all my cases. And second aspect is I keep the IP off during chopping, because I need a good grasp on the nucleus. And when I'm using only torsional phaco for quadrant removal, I keep the IP on. Yes, Chitra?
Yeah, no. All your points and what Anurag added are same, and the only thing is IOP again. Now we normally keep it at 30, so otherwise I don't think I could even question a single step of the surgery. It's all gone very well.
Really?
For once.
Really? Shall we start court martial now itself? So, sir, excellently done. One or two points, if I could mention. It was a grade 3, grade 4 cataract. Now, when you started the direct chop, you did not go right to the center core. If going to the center core definitely gives an advantage. If you have the chopper coming in from the periphery, then it breaks up the whole of the piece, and then the other pieces also you have an assessment of the depth to which the phaco needle can be buried in. So that becomes quite important, and especially if those fibers, entangled fibers are there. So you know that this much of fiber is still holding the pies. Then when you're pulling up one piece at a time, then you know that if there are just minimal fibers, it will just come up and you can gobble it in the quadrant mode. If there are more fibers which are sticking together, then what I do is I lift it up and manually sever those fibers with a sharp chopper, which immediately severs that pie, and immediately the pie is gone.
So actually, I'm doing a multi-level chopping. Whenever I'm chopping, when the fibers are still interdigitating, I go at a deeper level and chop again. I think I'm just making sure that each time I'm getting a complete division. A few fibers may be there.
I think wonderful surgery. What we have learned from the discussion till this time is, one, Dr. Ramurthy stressed protection of endothelium, repeatedly, dispersive viscoelastic coating the endothelium, multi-level separation of pieces, which is very important, and effective phacoemulsification, if possible, within the bag or subpupillary area, which have been seen very, very nicely. Few points which I do from my side is, normally for all hard cataracts, I try, doing a deep trench. We call it crater. Rather than trench, we call it crater, which debulks the central hard nucleus core, you are left with a slightly lighter periphery. Make sure you don't go too periphery also, otherwise the hole becomes very difficult in these cases. So crater and chop is our technique, and it gives a very nice effective management of these patients. I personally, for the last few years, I don't use IP at all nowadays. I just use torsional for all cases, hard cataracts also. Because sometimes IP is risky in a, especially hypermature type of hard cataract where the capsule little floppy. And suppose I have a 10 pulses fixed. So if I put a pressure on the foot switch, 10 pulses has to come. You can't stop that 10 pulses sometimes. And that might, for a beginner, hit the capsule sometimes. So I'm very careful now. People, my students know I don't use IP at all for last 2-3 years. Because you can still manage with the torsional effect also. And 50 is my standard power for hard cataract. Rarely I go to 60 torsional amplitude. Otherwise, recently I shifted to a very supra hard cataract. I use my loop nowadays to break the nucleus into 4 pieces. Then that makes life very simple sometimes. And such pre-chop division of nucleus people have talked about, pre-chopper of AIOCMTC people use. I saw recently with Dr. Ronald Hugh showing video from Singapore. People use that, but in India we have not been using those instrumentation because we are good in surgical chopping as such. So crater and chop is a good technique. People can divide. We have seen various video. People do a direct cracking of nucleus, like Dr. Rajendra Prasad from Delhi. Sometimes those are very tricky, and for a beginner, maybe very, very difficult to crack also. And that process, granules can get damaged. So better to debulk the nucleus, which you saw in this case, and do a subsequent chop effectively. Supra hard cataract, sometimes the middle part, it doesn't get cracked whatever you do sometimes. So sometimes you have to do a piece by piece, picking up the pieces. You're left with a central chunk also. Normally
I'll show some video
lift.
like that also.
You have that case.
Yeah.
This could last a little lift and eat the central area, and that breaks the pieces in multiple. That's a very good technique.
I think very, very excellent points, and I think this is exactly what I wanted.
Yeah.
Let me show you another situation. So hard white cataract, I thought it's an intumescent cataract, and as you can see, whenever the rexis starts pointing out like this, that means you are at risk. I mean, this is when there is a tendency for it to run off. I managed almost a 5 millimeter rexis right through, but at this step I seem to be getting into trouble. So what I do is to go in with a I pause for a moment, decide what is to be done, and yes, it's running. And then I go in with a micro rexis forceps through the side port and hold it there, and I'm able to complete, except for the slight rounding off the rexis. I thought everything was well done, but when I do a hydrodissection, you can see that rexis run off. Here you can see that it's run off to the periphery. So obviously I have a reasonably hard nucleus. Though it was a white cataract and intumescent cataract, the core is quite hard. So I am cognizant of the fact that can always be a wraparound. So I am careful. You can see the intraocular pressure is 30, and as I mentioned earlier, it's only longitudinal phaco. You can see my movements are a little more careful and tentative compared to what I was, because that rexis, especially with a hard nucleus like this inside, always has a tendency to, but once I split it into half, I bring the nucleus fragments into the anterior chamber, and just in foot position 2, I go ahead and crack the nucleus into multiple smaller segments. So obviously here again the same principle of dispersive viscoelastic with a lake of HPMC, and then I grasp the nucleus fragments one by one, and then it's a pupillary plane phacoemulsification. All the time I'm using also the chopper to protect the fragments to the extent possible from hitting on the endothelium, and it's not a continuous buzz of phaco, but then as and when it's needed. And then of course the intraocular lens go in. I did escape this time. You can see a fairly large discontinuity over here, which happened in spite of my initially completing the rexis, but during hydro I don't think I injected excessively, but even that little pressure was enough to make this rexis run out. But I did manage. So obviously we do face these situations. So yes, Dr. Titial.
I'm just thinking how beautifully this case was managed, because we keep during the entire nucleus management, our heart is always beating. Is something going to go wrong? Something going to go wrong? You're waiting for the end in these cases, and sometimes towards the end, I saw that very nice technique, leaving the nucleus pieces to that side to cover that area, because the bulk is going to cover, maintain the pressure so the tear doesn't extend posteriorly. And towards the end only you took the last piece from that area, because that has to be protected till the end. And beautifully managed. I think the main trick we have done is a low IOP phaco in this case also. Whenever we have a damage or a broken rexus, I think that's a very important part. Not to let chamber get collapsing in any stage of your surgery. Especially when you come out towards the end of phaco, you think that you're completed, you suddenly come out, and the posterior capsule comes up because there is upthrust and tear extends to posteriorly. And that can also happen after implantation IOL also. You implant the IOL, when you come out, the tear goes backwards. But that's a safe time. But when tear goes posteriorly during the nucleus management, then it's a very difficult area. So always, before I come out with the handpiece, I'll inject dispersive viscoelastic on side port to maintain the anterior chamber, so the tear doesn't get extended to posterior side, and manage effectively. If possible, if little bit of anterior dislocation or nucleus which you have done is going to really help in this case.
Excellently done surgery, sir. 2 points. One is, why did the rexus run out in the first place? Because you
Yeah,
completed it very well with the forceps. So why did it? I mean, there could have been a tag left. Yeah. Yes.
Yeah, there was a slight, and I'm not even inject too much fluid. I mean, but
So this is quite a rare situation, I would say. So that is one. The other things I would have done differently, because it is sitting tightly there and a large nucleus is there. So one pie I would first dislodge and bring it out so that there is enough of space in the capsular bag, so that the divisions of the nucleus, yes, that pie, that first pie, to be taken out and to be moved away, so that you have enough of space, and the axis of your runout was very much in that same axis where you're dividing the nucleus. So that gives it more stress to the zonules at that part. So I mean, you have taken adequate and more care for this, that only one pie to be removed, and then the rest of the pieces can be taken off.
no, I think it's a very important point. But that, where else could I have chopped? In the sense that I know that it's sub-incisional, but I can't chop in the 3 o'clock or 9 o'clock. And one other thing, I think,
a little on
little
the
angulated.
angle,
Okay.
a little on the angle, if the chopping could be, I mean, basically it is to diffuse the stress on the zonule in that axis.
So if you have any additional points, otherwise we'll.
No, I think the main another thing which was also already said was, manipulation should be done away from the area of weakness than the direction of thing, and the final placement of the haptic of the IOL should also be ensured that it is away from the area of zonal extension, so that the optic has a proper wrap in most places, and all this becomes more relevant when you are doing a toric IOL case.
I was also going to make the same point that Dr. PB made. I always make out one pie, clearly cleave it out of the whole area, and then take it out so that it gives me more space. Not only does it give me more space, but the other part of the nucleus is largely undivided as yet. So if I have to levitate, if the nucleus is dipping and I can see the tilt, if I have to levitate, you have an undivided nucleus, which is always easier to levitate rather than having smaller pies and pieces running here and there. I think you've done a brilliant job, sir. I think you are doing the chopping not along the area where the split has happened. So
Slightly to the
that's actually, that's exactly what the point was being made out. So you've done it brilliantly. The only thing is, these are the fluid-filled pockets in the mid-periphery which has actually caused the tear. It is not your fluid. It is those fluid-filled pockets which actually play very, very notorious in cases like these. So at times, it's not always possible, I agree, but at times, after completing the rexus with the hydrocannula, or sometimes even with the cystitome, if I have managed to complete the rexus with the cystitome, without any hydro, I try to mechanically rotate the nucleus. It sometimes happens. And if it happens, even a small twirl can break the septae of these fluids, and they come out in a bulk, so that you know, the intracapsular tension just goes down a bit. That's the only thing I try. If I'm successful, if it's giving me resistance, I stop. But if it's rotating, then it might just release those fluid pockets.
Perfect. I think one take-home message would be that in spite of the injury to the endothelium, risk of many of the maneuvers can happen after the lens is brought out of the nucleus fragments are brought out of the capsular bag, because here you do not want to do many maneuvers inside the capsular bag at the risk of damaging its integrity. You can see a brown nuclear cataract, LRCS has been done. You just see that even in these brown cases, there is some impact of the laser, and you know, deep down you see that there is some amount of nucleus splitting up that has happened. Here again, the principles are essentially the same. It's again being run at 2x speed, and this is just the nucleus being chopped, and then subsequently, what do you feel about the relevance of laser in these cataracts, Partha? Would you like to comment on that? When otherwise the steps are somewhat similar.
Yes, sir. So very important, sir. I mean, the steps of the flax, which gives a lot of attributes to such hard cataracts. The first and foremost thing is the division is made. So when the division is made, we need to identify the division channel that is already there and just to separate it. Now, at times it is not so visible, and thereby we go about chopping in an area that might be a little in proximity but not there. So then you have the direct chopping, what you would do without a flax. But actually visualizing that part, and once it separates out, and because the posterior plate is also well separated, all the chunks and all the pies become very, very clear. So that is one thing that we need to pay attention to. And I would have also done the same technique without softening in this, because softening I'm not too fond of unless it's a very hard cataract, and leaving an amount of the nucleus, and beyond that the softening takes place, because otherwise it tends to eat up and you don't get a purchase of the
Actually, I would beg to differ on this. Definitely these hard cataracts, I do soften them, and then, you know, usually create cubes of 200 microns. Though there are some who believe that small fragments sometimes go behind the iris and stay there, so make it at least 300 to 350 microns. Any ideas, Dr. Tityal?
No, I agree to your point. I also use LensX system for a very, very long time. I do a hybrid pattern, which has a grid and chop pattern in these cases. And my offset is also towards around 500, 700 posterior, so I go a little deeper. Otherwise, separation becomes very tough. Unlike the soft cataract, you can be little up, you know, like posterior, I keep normally 700, 1000 posterior polar cataract. Here, go little deeper. And if laser effectively done, then you have a very nice chop coming up. You can separate that chop very easily, and surgery becomes simpler. Unless it is a very super hard cataract, sometimes it doesn't happen in those cases. Like white cataract also, it hardly affects the nucleus at all. But these type of cataract, I normally prefer a femtosecond laser device, which we have done a studies also where we have decreased our phaco effectivity almost 50% in these cases. So which is a real advantage.
Absolutely. I think almost I also find roughly it's about a 50% impact, and it's only a question of white cataracts. If laser light can pass through, there's always an impact, even in hard cataracts.
in this one, the cleavage planes were not very well defined.
Not very clear, not very clear.
So that's because with the, I think this was done with the LensX.
No, it was done with the catalyst.
Catalyst, okay. So what LensX does is, if you are doing a grid pattern in that, so the grid is at the center and the cleavage starts from the mid periphery. So it doesn't travel to the center. So the grid happens at the center, and from mid periphery the pies start happening. So the cleavage does not run straight towards the center. It gives you a very good softening effect. But the other thing is, I mean, the huge advantage with the laser in such cases is the energy is applied from bottoms up while doing the nucleotomy, and all the while the energy is protected by the capsular sheath, so it doesn't hit the endothelium. So we are dividing the nucleus without causing any energy mediated disturbance to the endothelium. That's the biggest
And also
advantage.
an excellent repeatable rexis that you get,
Absolutely.
which is very important. I think we'll
Sir,
just
one-
pass on.
one point
We
if I
should
can-
do because there are so many fragments and a lot of cavitation bubbles. So And since we are increasing the offset also, we should definitely allow egress of the cavitation bubble by tapping intermittently.
One thing in this, the company people always, application guys always said that there could be a possibility, that rare possibility of a burst of the posterior capsule. But over all these years, I've never had one such instance, even with
No,
the
that
hardest
was
of cataract and with so many cavitation bubbles. At times, the cavitation bubbles come only later when the pies are getting dissected. But it's never happened.
no, that was something, Michael Lawler's original paper when they had just a initial experience in 2010-11 that gained a lot of prominence.
Most of
But
the
then,
time these bubbles are intranuclear bubbles. So that's not going to damage the posterior capsule at all. That's why when you open the job, then it comes out. Then you have an epinuclear cushion, then these bubbles, rarely this bubble can be taken out during your hydro procedure. Tap it. Normally what I tell my my younger people, if you see a bubble to a 4 o'clock side, start your irrigation from the other side so that you can get the bubble up. Rather than trying to inject from that area where the bubble is there, it goes to posteriorly in the middle, then you can increase the pressure.
and just pressing on the nucleus before you inject, that itself most often brings out the bubble. I think sometimes you're not able to get complete chop. Let's look at a case like that. And I think otherwise the Rexis again, the reasonably good sized Rexis. And what the point that I think Dr. Partha was trying to make, where you're not able to really chop them completely. I was a stop and chop surgeon for a long time. And whenever it's a hard cataract, soft cataract, semi-soft, whatever, when I find that I'm not getting a good separation, then I don't go ahead persist with chopping. But whatever initial trench I have created, I just go ahead. As you can see, I'm trying to chop. Maybe my maneuvers are not as perfect as it should be. I do see some separation, but I'm not quite happy. I rotate it around. I still am getting something, but not as good as a complete division. So what I do in these cases is to go ahead and convert the central trench into a longitudinal trench all the way, and the basic idea being that for dealing with these cataracts, especially where the zonules are a little weak and maybe the capsule itself is scant trampoline, it's important that you have a complete division where the backbone of the nucleus is broken up. It's not a question of ego that I started with chop, I'm going to persist with that. So what I'm doing here is I did an initial chopping, but I was not quite happy with the kind of division that I had. So what I made a deep trench in the center, and now using just two Sinskey hook, I am separating them into two heminuclei. They are all partly chopped, but not as well separated as I like them to be. And now I am using adequate viscoelastic. I am bringing into the in the pupillary plane and going ahead and emulsifying the nucleus. I mean, if you have this kind of a situation where the chopping is not complete, anything else you do, yeah, it's not as nicely separated as you'd like it to be, Dr. Titial.
We have discussed most of the point in these hard cataracts.
Yeah,
also.
we can.
I was
briefly.
just, looking all your videos. Your pupil is always moderate. They never. I'm curious to know what would be, what is your, fluid management, that irrigation fluid which you are using. Do you use some sort of adrenaline in that or
Yeah,
not?
we do add adrenaline. These
Despite
are
that, see this again, 4 mm pupil, and it normally.
these are slightly challenging cases. We have a lot of. I'll show you a prelex next where they will be very well dilated.
So it should also reflect on the ward sisters putting all the drops for a 1 o'clock patient at 8 o'clock.
Ah,
So
and the
I
by the time
saw
pu-
a series of pupil fatigue.
pupil fatigue.
We do use in such cases a combination of adrenaline and xylocaine in the beginning. As soon as the site ports are made, does have a limited impact.
Especially I was discussing with Partha also. Whenever I have a seriously hard cataract where I feel I can't chop properly, then the pupil dilatation is very important to see the peripheral area because you are not hitting the right area for chopping also. So these are cases of where I might think of using iris hook at this stage to give a more access to a nucleus management. But if things are getting like this, where I'm thinking, okay, things are going quite okay, I might proceed the way you did also. Wherever you feel little difficulty, you're not holding properly, not chopping properly, expand your pupil, see better, and then you can do a better job. Don't try to go through and through without having, unless you have separation like this, you should make sure the visibility improves. That's the only way I can say.
Any quick comment?
Yeah. So I think you did a great job in this one, and separation to that last plate and with a smallish pupil is very, very important. Otherwise, that pie cannot come up. Maybe if also you could have done maybe gone in a little deeper, a little more of phacoemulsification and that last plate part, so that the division with your two separators would have been a little easier.
Yeah, he could have made a slightly deeper trench maybe.
Very nicely used, only Tosco here.
Yeah. And let's look at prelex. You know, I think previously it was considered a sacrilege to remove a lens when cataract is not there. I would definitely not do it in for situations of high myopia. But these are patients who are coming to us. For example, this is a 56-year-old lady with a plus 2.25 diopters for distance, and reading there's another additional 2.25. Her son actually underwent SMILE and he was about 21, and then when this lady came for the post-op checkup, she said, what about me? And these are actually nowadays we have started doing quite commonly these situations, and a fairly clear lens and a plus 27 diopters is the power that goes in, and the surgery per se is nothing very difficult. And what's your concept? I mean, do you do prelex? Chitra, you would like to comment on that? I mean,
I think this was a hyperopic patient, and in mid-50s, if you have an access to eye trace for your own mental satisfaction, if you look at the dysfunctional lens index, but this was already cataractus, it's not needed, but if it's nearly a clear lens, but the patient is coming to you, you do an eye trace, you realize that his dysfunctional lens index is actually much on the lower side, and that is why he's unhappy, because the quality of contrast and all is quite affected, and aberrations are also there. And being a hyperope, you can really do a very good job of doing a good cataract extraction and putting a multifocal or a continuous range of vision lens, or even rarely if the patient is very particular about glare, you can put a enhanced monofocal or a VVT kind of lens. But these are ideal scenarios for doing a prelex with the kind of biometry and IOL formula which we have.
Dr. Chitial, we are all in private practice, so there is a motivation for doing this. What about you? Institutional practice, would you do this for a high probe?
It all depends on how patient perceives the situation. These are patients, they may be correctable to 6.6 by glasses also. But plus 2.5 for distance, then adding another plus 2 for near, it becomes a 4.5. And sometimes that can be very disturbing for these hyperopic patients, because they assess using glasses throughout their life and now getting another addition. And we can have if the lens is clear, and as Chitra was talking about, DLI is better. But sometimes if AC depth is there, I can think of giving refractive phakic IOL of like presbyopia phakic IOL, though experience for these cases are not long enough for us, because many patients do develop early cataract after implantation also. But yes, if patients are willing, I might go for the same. So we do have now for last 5 or 6 years, number of patients demanding clear lens extraction is very high now. So we do a lot of cases with clear lens extraction, especially with the trifocal lenses and the lenses we have nowadays, very good results. And I would have also gone the same way as you did. So it
And
is not
actually, I have an arbitrary cutoff. You know, I heard about your experience with presbyopic phakic IOLs. Now I also started doing it. So up to 40 is essentially laser vision correction. 40 to 50 is more of a presbyopic phakic IOL. When the patient goes beyond 50, of course DLI is something we look at. But sometimes even if the DLI score is good, and I have a situation like this where the patient is demanding essentially a refractive surgery, then I go ahead and implant these lenses. And a lady like her who is not driving in the night, is often, we do tell them that some amount of dysphotopsia will be there, but they do accept it.
The same thing for our myopes also, higher myopes also. We do a option of a clear lens extraction in those cases also.
No, higher.
Where? There also sometimes because they all have a sort of a nuclear sclerosis coming very high in a myopic patient also. And DLI is always poor in these cases. So if you have an option for giving that, can also be, we have some group of patients in that category also, not only hyperos.
We are very wary of
Very
doing
on-
this in
yeah,
myopic
high.
patients because of the severe
Yeah.
retinal complications.
Unless they
Only
have had
situation, significant nuclear sclerosis, very low DLI. And most importantly, if there's a complete PVD,
DVD.
my retina surgeon says that, the
At least.
periphery is pristine, not much vitreous floaters.
Yeah.
Because I have had a couple of cases long back where the patient ended up with a retinal detachment for a high myopia because there was not enough depth for putting an AC depth. And yes, I think there's almost a 8 times increase in the incidence of retinal detachment subsequent to clear lens extraction or any phacoemulsification, really high myopes. So you can use it as a last. And this is just a final slide showing why exactly is Prelex gaining popularity, because we have accurate biometry, good formula, good optical biometers, so that we are confident of hitting the target. Availability of good premium intraocular lenses, trifocal, continuous range of vision lenses, etc. We are quite confident of our surgical outcomes. And obviously, all of us, I am excluding Anurag, all of us still in our 50s and 60s want to lead a very active life. And the desire to get rid of glasses, if possible, is always there. So let me skip this. I think we'll let me come to this. It's not a very bad subluxated cataracts. I know this session is essentially meant for taking home simple points which you can employ in your practice. So you can see this subluxation over here, that it's got a post-traumatic, and the patient preferred a LRCS. And obviously in these situations, access to this is a good idea because you are able to get a nicely centered rexis. And in this, it's a reasonably softish cataract. And here again, just like we discussed earlier, where there was a rexis runoff, it's always a good idea to bring the nucleus into the anterior chamber. Obviously, there is going to be a little more, and that's the dispersive viscoelastic that's going in, coating the endothelium quite adequately. And then I'll also put in some HPMC. I always like a lake of HPMC where the actual phaco is happening, because the dispersive viscoelastic can be thermogenic. And most of the emulsification happens in the AC as posterior as possible, a reasonable CDE. It was not a hard cataract. And now I'm going through the, I know there's a lot of very relevant messaging about pars plana vitrectomy, but I hardly ever do this because in my hands at least it works quite well. And as you can see, I went through the just the subincisional area where the subluxation was there, and I go ahead and do a limited anterior vitrectomy, then inject some diluted tricot, triamcinolone acetate, and you can see a strand of vitreous over there. Without its irrigation is separated, I go ahead and remove, do an anterior vitrectomy, so that there's no vitreous there. And since I don't, since the capsular bag was quite stable, I postponed the introduction of the endocapsular ring as late as possible. I could have done this earlier, but then I was confident that things were not going haywire. So I put in an endocapsular ring, and since it's a traumatic cataract and the subluxation is not likely to be progressive, I go ahead and implant, just don't resort to a CONE or a Ahmed segment. That's the end of the surgery. The patient actually received a toric trifocal lens. That's the post-op pictures. You can see a very minimal decentration, but I think the patient did well. Comments?
Yeah, I just felt you did bring the nucleus up and did the phacoemulsification, but it makes sense to put a capsule hook there to keep it stationary, because when we do phacoemulsification, we are also, and there's vitreous there, we are hydrating the vitreous, so more vitreous would come and that area of dialysis could increase. So keeping a capsular hook would be.
I think I agree to Chitra at this point, because you had a subluxation from 7 to 9:30 o'clock. So maybe I would have put one, because we have become all temporal incision surgeons. So that's the area of, normally for a subluxation we say don't do an incision in the same area of subluxation, but now all we have not trained into a temporal area surgery. So maybe one or two hooks I would have placed there just to pull the entire back toward that side, avoid the vitreous getting more damaged. And during vitrectomy also, rather than using the main port, I would have used the other side from other side to do a
No,
vitrectomy
the
from there.
thing was the accessibility to the
Yeah,
side ports
yeah.
would have been difficult. I mean, in
And
the sense.
I think people have there, like Abhay Vasavada group, they would have gone past plana and then a vitrectomy there also. But we as an anti-segment, it's very difficult for us to plan past plana. Otherwise, you nicely did a CTR towards the end after aspirating the other areas, because sometimes CTR per se will decrease the total cleaning of those fibers also sometimes. Difficult to pull out the cortical fibers. But effectively well managed, and this I think the area of visibility of entire lens was much better for doing a laser capsulotomy in these cases. So sometimes if the lens is shifted to one side, you may have to shift your capsulotomy to a area which you have a larger area of visibility and do. And maintaining the bag is very important. Luckily this had a slightly smaller dialysis and post-traumatic. That means other area was normal. So you did a I think good job of putting multifocal eye in these cases also. Many people may not put it. But traumatic, we all understand the other journals are intact and they're healthy, so nothing much will happen in these cases.
Patient was very clearly explained that we may resort to even a 3-piece lens depending on how the surgery goes.
So just one or two small points. One is because there was a temporal luxation, so I think my approach would have been from the superior side. Number one. Number two
You're
is
so averse to shifting from
yeah,
temporal.
I know, sir. The second thing is this the lens coming out itself, so that could weaken the zonules a little more. So the lens in the bag itself and very gentle hydrodissection could be another small technique. The third is remembering the fact that the luxation might increase. So there the if you have to put a CTS, then it has to be in that quadrant, I mean in the temporal quadrant. So the temporal quadrant must be kept for the CTS as much as possible if it increases. Here it was very nicely centered and just with the CTR, but there could be situations where a CTS might have been put and the sutures or a Hoffman pocket and everything. So इसमें तो जरूरत नहीं था, लेकिन अगर
this certainly is not a case where you expect a progressive zonulopathy. This is definitely a stationary one.
But you might not be able to assess the
right.
amount
so
of
the intraoperative
dialysis.
stress could also just extend it. But these are situations where I would have done a chop with a laser, not a grid, so that there's a clear cleavage and we have 4 different segments which can be brought out. And perhaps at the initial part when the dialysis is already showing and it is evident that the vitreous is peeping through, I probably would have done a limited vitrectomy and put in some dispersive viscoelastic to plug that area so that the vitreous doesn't come in the way of emulsification before even starting the rest of the emulsification process. But this is the part that I would like to stress upon, sir. I think you've wonderfully exhibited that. This is something we all have to remember.
Yeah.
The dialyzed portion of the bag is the weakest, and the eyelet of the CTR should not be placed where the dialysis has happened the most, because that's the weakest area of the CTR. That doesn't put an equatorial pressure to the same extent. So you started bang opposite to where the dialysis is, so that the eyelet also ends somewhere on the lateral side, and you have maximum stretching of the CTR happening in the area where the dialysis has happened. So that's beautifully taken.
No, another practical viewpoint, we hear a lot of presentations about in these situations doing a pars plana vitrectomy, and it does work well. But practically in your surgical practice, what are you doing? Anterior route or?
Always anterior route. I think in my entire career, I've done 2 or 3 cases, tried pars plana vitrectomy in cases where the vitreous management, where it was very difficult to, unless you plan it beforehand, you need to do it.
No, sir,
Intraoperatively, making the port is so difficult.
If Titiyal sir has tried on 2 to 3 occasions, the message is don't try it.
No, I think Maipal does some pars plana vitrectomy in these cases. I mean, as you came, maybe we can start.
No, I really don't know what the discussion is, but Okay, in subluxations, when we have, okay, so we do it beforehand. In phacolytic glaucoma, phacomorphic glaucomas, we do it whenever, so that's, we call it as a third hand.
Yeah.
So you don't actually need to go in and do that, you just need to put it down the port, and whatever is there, it
Fluid is-
kind of comes out. And then you go in and remove the vitrectomy, do whatever the vitreous is there, because this will stop it from coming forwards. So you have, like Abhay Vasavadra has also shown, when you do a vitrectomy, it should be a posterior approach, and then you put the, I use a femto. So we have published it in, I don't remember which journal, Journal of Cataract and Refractive Surgery, as the third hand. And we use this pretty often whenever there is a large subluxation and things like that.
Yes, I mean, different ways of skinning a cat, but I think still most of us are quite comfortable doing it from the anterior route, though I think several publications are there supporting the pars plana route. Let's look at this case, advanced Fuchs dystrophy, maybe of specific interest to Dr. Tityal. You can see this was the specular microscopy. We hear all about this 600 cutoff and other things, endothelial cell count when you will do a DSEC with it. And this was what the bilaterally the patient had. And actually a patient fairly closely known to me, quite a well-to-do jeweler. And this was his slit lamp picture. And I went ahead and did this. And phaco and fix, essentially there's not much of a change in the procedure per se, except for the fact that you will do everything possible to do a posterior plane phacoemulsification, use moderate settings, slow motion phacoemulsification, and all the time use dispersive viscoelastic multiple occasions to preserve whatever endothelial cells that are there. Of course, you would have had a significant discussion with the patient as to that he or she might require a secondary procedure like a DSEC once if the cornea decompensates. Let the video run. Dr. Tityal, your comments with a specular microscopy picture like that, with a clear cornea, would you still go ahead with a just a cataract surgery, or would you do a combined surgery?
Yeah, routinely as a cataract surgeon, we would have gone for primarily a cataract surgery for these patients. And sometimes these patients do well after cataract surgery. Their contrast improves, vision also improves sometimes. But I will always keep them ready for a requirement of DSEC or DMEC subsequently, which may be needed in these cases. Primarily, unless the cornea is showing some sort of epithelial edema coming up, the cornea thickness is around 600 plus, and the central area is getting little thicker, and patient vision is getting poorer every day, and it doesn't really commensurate with the cataract hardness or a sclerosis, then primarily I might do triple in these cases. If cataract is more significant, a cornea like this, I would have done primarily cataract surgery, wait for next 3-6 months, 1 year sometimes. I have a patient who have waited for 4-5 years without requiring the DMEC or DSEC also. It's not that every patient would require. The only problem of these patients is they have a little more edema in the post-op period, which takes some time to settle down, maybe some sort of hyperosmotic agents to be given. I wait for the next 2-3 months, they are quite alright subsequently also. If needed, then surgery should be delayed at least 3 months post-cataract surgery, then plan for a DMEC or DSEC.
This is actually the 1 week post-op picture.
Done
And
very well.
I am quite surprised. I really do sometimes wonder how relevant or reliable is this SPM. A picture like that earlier days I would have been very worried. But I have several cases where we have had not completely absent, unrecordable, but then the cornea looks reasonably clear, though you see quite a bit of gutte.
So that's
do a primary
that's
surgery.
related to the thought that I was about to share with you, sir. In fact, was about going to ask you that it's a thought now that more than the specular picture, you should look at the anterior segment OCT and the detachment thickening that is happening. If that is within normal limits, then perhaps this particular cornea can take the surgical stress and go ahead with cataract surgery and keep the corneal procedure for later. How far do you support it?
We would do 2-3 things there. One is, you have to look on a patient's symptom is one important thing. Early morning blur coming sometimes, and symptom is the one which might warrant you to do surgery, like difficulty in driving. There are patients who have no cataract, but they do have little these changes, and they are quite disturbed by the evening light hurting their eyes. Difficult driving, we might do DMEC in those cases. But yes, if they have hardly any symptom, cornea looks less than 520, 530, and the endothelium which we assess by ultrasound also, you can see the little bit of irregularity coming up. That indication that cells are not actually functional in these cases. So these cases may require a triple procedure subsequently. Otherwise, normally we'll go with a cataract surgery as such to begin with, then plan subsequently. Rarely we do a triple procedure, that too in a second eye. I've done primarily a triple for a patient, or I've done a DSEC, DMEC subsequently. Those cases I plan. Otherwise, primarily for all of us like these cases, only cataract surgery. Observe your patient subsequently by looking for corneal thickness, parameters, specular, patient symptoms, then plan. Otherwise, no need.
Just to add one more point, which I'll just wish to say, from the perspective of what you have said, surprises on the positive side are plenty. So I always prefer to do cataract surgery alone with all the things that you have said. In the post-operative period, one of the most important things apart from hyperosmotics, I don't believe too much in hyperosmotic, is to use atropine. Because it has been clearly shown that there are endothelial down regulators which are produced by the ciliary processes, which are 12R HET heat and 12S HET and prostaglandin.
You surprise me, Mahipal.
Why?
What is all this?
No, this is all this that I am telling you, that these are endothelial down regulators. See, there are cases of corneal edema that you have in uveitis. Why do you have corneal edema? Because there are endothelial down regulators which are produced within the eye. So giving rest to the ciliary body is very important, and that reduces the amount of endothelial down regulators that are being produced, and that will help you improve the corneal edema much. Hypersol and all is just you just symptomatic kind of, you're just removing. But atropine, just try it whenever you have corneal edemas. In SK also that you have in hard cataract. On the table, if the patient is under block, I give a subconj atropine also, and I continue with atropine. And they tend to clear up much faster.
How long do you have this atropine going?
That depends on how the corneal edema is going.
But you
Three,
don't
4
have a
days,
problem with the
huh?
you don't have a
Doesn't matter, the
pupil
patient
getting
will have
fixed
some
and
blurry vision. Either case, the patient is having blurry vision because of corneal edema. So that's really not an issue. The point is that you don't want permanent damage to happen, because longer the corneal edema remains, there are potential some more cell loss that you are going to have. Because this is well established, and this goes back to my studies that we did in 89-90 in US. So that's why you were surprised. And these were published in investigative ophthalmology.
See, remote memories are better than recent.
considering that, sometimes there's a IOL power calculation. So, if this patient has to go for a DSEC, would you do something about that?
Nowadays we do, most of us are shifted to DMEC procedure. There hardly any shift of IOL power to be done. But if you are doing a DSEC, then maybe you keep little, myopic IOL power so that it compensates your additional hyperopic shift happening with the DSEC. Because sometimes if you are doing a more than 150, 200 thickness in the stroma, then you have a hyperopic shift happening in these cases. That should be planned out. But if you are doing DMEC, it's same as normal case, hardly any matter. Sometimes we do use, these row kinase inhibitor nowadays. People have a good experience with those. And we have recently concluded one study in the RP Center where we use row kinase inhibitor in one group and one group no row kinase inhibitor, where my CD was more than 20. That means they are hard cataract, to just see how effectively that changes. But there is no significant difference came out subsequently also.
So
but
no.
Stop that, just to see how is it really going to make a difference in the hard cataract or so. In Fuchs, people have reported. In fact, it's the one study from India they have used for all corneal edemas, and it has shown that it improves the corneal edema subsequently also. But there are some cases they can have the epithelial edema coming up, honeycomb appearance, and patient has the painful eyes. That you have to look into.
I also put these patients with striae or significant striae of post-op corneal edema, not just cases of Fuchs, or for a couple of weeks on Timolol twice a day, just to keep the intraocular pressure slightly on the lower side.
I agree with that. That is an additive that's an additive that I also give, because higher pressure pushes up more fluid into this thing. So yes, you reduce the pressure. And post-op, I think people are slightly afraid. My co-consultants and all, I tell them, if you have a high pressure day one, I just depress the lip and take out the fluid, and the pressure falls like. Yes, ma'am. It's a sterile. You just have this thing, and
That I'm not surprised.
yeah. No, it's basically you're not entering anything. It's a pressure going out. It's not something going in, and the eye is tight. Like supposing if you have a 50 millimeters of pressure or whatever it is, the moment you just press it with the lid. You don't have to, wherever your side incision is, just press it there at the limbus, posterior limbus, and let the fluid come out. Because mannitol though, diamox though, glycerol though, it will take much longer than just decompressing the interior. If you want to do it, go to the OT and do it, or just wash it, because this is residual viscoelastic which has caused the pressure to go up. So you. Or anything above 35, 40 or something else. It has to be high pressure, that's what I am saying, 40, because you don't let it remain. So it works like magic. No, 20-25 पे नहीं करेंगे.
Let's look at a posterior polar cataract, a common scenario. A case with a formed nucleus. Obviously, no hydrodissection, it's just a hydrodilation. Again, the video is being run at twice the speed. So what I do is no rotation of the nucleus, I debulk the nucleus. But this is a formed nucleus. So again, that minimal trench that I always make, which gives me excellent access. Without rotation, I'm just splitting the nucleus, into basically the inferior heminucleus is split into 3 distinct segments, and then I just remove each one of them. And once the amount of material in the capsular bag comes down, I am doing a visco dissection, because there's enough space and there's no pressure on the capsular bag. Bring the superior heminucleus inferiorly, and then go ahead with removing the rest of the nucleus, and that's the epinucleus with the posterior polar element coming in, and that's, I think, trifocal or whatever. I mean, lens going in. The steps should not have been any different whether whatever lens was used. I mean, in this kind of formed nucleus,
No, this was a little moderately dense cataract. No, it's not dense. But suppose it's a soft cataract, you couldn't have been able to rotate the nucleus even though you have created space. Of course, it allows you to do a visco-dissection, and that might enhance some separation. So I just wanted to add is, even if I could somehow complete the phacoemulsification, if at that point everything is fine, I wouldn't, definitely I'll do a visco dissection, but sometimes I would do a hydro dissection too if it's only the epinucleus shell which has to be dealt with. Huh? Not
No,
beginning, in the end, after the delineation.
Not dissection.
Yeah, delineation.
Don't dissect our
No, in the end.
I think this is a similar technique we have recently published in IGO, which we call, a chop and tumble. So we chop it like Dr. Ramamurthy beautifully has shown the initial 2-3 pieces. That gives a fluid to wave to complete your internal delineation. Then we just, with the second instrument, we just pull the nucleus to side. It comes out very effectively. That is tumbling the nucleus without rotation, and you can effectively complete your manipulation without rotation in these cases. Beautiful technique for a moderately hard cataract. Normally, all post-polar you have a soft cataract, as Chitra is saying. There, the technique of chip and flip works very nicely.
Any comments, Anurag?
No, sir, I think what sir is, I didn't know that it completes the hydro delamination after you remove the first
Even
two
if not
eclines,
complete, with your second one, you make a pull,
so that's
it
what
comes out.
that's what I used to do. I do a lateral chop after the first 2 octans are removed. I do a lateral chop and then levitate the rest of the nucleus without rotating it at all. And that's the basic principle that I think we all work on. So beautifully done, sir.
This is something different in the sense that almost 70% of the lenses I implant nowadays are toric intraocular lenses, Indian or imported, or multifocals or monofocals. 70%, yes. I mean, that's the reason actually my uptake of Indian lenses has also gone up. Because, no, that's exactly what I'm referring to. Previously, I don't talk about numbers at all. My go-to formula is not the Barrett universal 2, but the Barrett toric calculator. Often I am asked, what's your threshold? Whether it's 0.75 or 1 or whatever it is. You can see over here it's 0.60, and it's at 170 degrees. And because it's against the rule astigmatism, the patient still needs a T3 lens. And especially if the patient is going in for a multifocal intraocular lens. Of course, here the astigmatism is significantly higher. So I used to say 0.751, there used to be discussion. No question, just put the patient on the Barrett toric calculator. And if it shows that there is a T2, generally I don't implant, especially in a monofocal, maybe for a highly demanding multifocal patient. But looking at this is extremely important. You see the same thing with a 0.6053. When you see this, just because it's an oblique astigmatism, even though the amount of astigmatism was almost exactly the same as what we saw in the earlier case, there's no need for a toric intraocular lens. So rather than talking about the dimension of the corneal astigmatism, it's a good idea to go ahead and use this Barrett TK toric calculator. Of course, just in case you do not have access to this, then there is excellent form. All these formula is available on your website. We have multiple centers. There are a couple of, now we are equipped, all of them are optical biometers. But for some time they did not have, and they were accessing this APACRS, AACRS website. Exactly what I told you is possible here also. You can see that it's a 0.75, 180 degrees, obviously, but what the calculator, the online calculator, there's no access to an optical biometer, and what you see is a T3 is what is recommended. And go to the other end, it's with the rule astigmatism, exactly 0.75 at 90 degrees, and what you see over here is that you need it's a non-toric that's necessary. So basically, rather than talking about numbers 0.6, 0.7, 0.1, etc., I think the good idea, whether you have an optical biometer, it makes it easier. Otherwise, you can have a good reading with your Auto K and then feed the data into your online calculator. Use the Barrett toric calculator rather than the Barrett universal to decide on whether you want to go for this.
100% agree, and it will definitely increase our uptake of premium IOLs. And if once the patient starts seeing plano for distance, you will have a next segment of them coming for wanting reading also. So, and we are very happy patients.
What's your go-to formula, Anurag?
No, it's still the Barrett's toric only. But my threshold is even lower than yours. I start implanting from T2s, and I think last year's figures suggest me, I was just going through the papers yesterday, just before leaving for this place. I implanted, I think, 950 torics in the last calendar year, and 230 out of those were T2s. So I have a very low threshold when it comes to torics. Nowadays, I've started evaluating the Oculix formula as well, which comes in inbuilt with Anterion. And it actually shows me something very interesting. It gives me a toric requirement even depending on the pupillary size. So it's very, very interesting to look at. I'm not saying that it's my go-to formula right now, but I'm looking at it with a lot of supervision and keenness.
What is this formula?
The Oculix, the ray tracing formula, the Oculix. The ray tracing formula that comes with Anterion.
Any comments, Dr. Tritial? What is the formula that you use? Yours is a very large multiple surgeon setup. Barrett.
Barrett's toric.
Last of the videos, and I mean, I think it's just a, it's a Morganian cataract, and I think this is a very nice technique to use. Amar Agarwal mentioned this. Initially, I was very wary of it. I thought with the nucleus inside, if you go ahead and do a implant a lens, there will be very limited space. As you can see, this hard nut usually rotates very easily, and then these elderly patients also have a tendency for the posterior capsule to trample in. So I put with the entire nucleus in, I put the single piece lens in the capsular bag, and of course these can also be used when there is a PCR. That's a different scenario. And even though it appears like a brown hard cataract, there is very little phaco power that's used, and intermittent phaco power and good protection of the endothelium. We are able to use this. Use this.
It's a very valid way, and probably the best way of doing a hypermature cataract like this.
I think we saw that there's a scratch made on the nucleus, so probably you tried to chop it while it was in the bag, and then you retorted to the other technique. So what I do in this is not definitely using the scaffold as a primary choice, just like you. The only thing that I do differently in this is after completing the rexis, when I'm trying to chop it from the other end, I take the chopper and support the equator so that it doesn't rotate, it doesn't flip, it doesn't slip. It just gives me an additional anchorage just to chop it. And it works most of the time, it does.
Thank you so much. I really value the participation of all the panelists, very useful inputs. I learnt a lot, and thank you all for joining. Thank you so much.
It was a good session.